Now, moving on to our third section, that is, as you know, the humerus is actually divided into a proximal 1/3, middle 1/3, and less distal 1/3. We are moving on to the middle 1/3 fractures, that is humerus shaft fractures. In this section, we're discussing the clinical features of humerus shaft fractures, what are the non-operative indications, the operative indications, and what are the special features of humerus shaft fracture in case of the children. Now coming to the fractured shaft of the humerus. Mechanism of injury, as I told you, it could be a spiral fracture, as in this case due to fall on the outstretched hand and the hand got twisted or stuck, and the body was either rotating or the body was straight but the hand was stuck in such a way that it got twisting injury. When there is a fall on outstretched with a twisting kind of injury, it results in a spiral fracture. This could be a simple oblique or transverse fracture. Oblique fracture could be due to fall on the outstretched hand, or when the body is angled at a certain degrees. A transverse fracture could be a direct blow or usually resulting from the fall as well. When the arm is abducted most of the time. There is a transverse comminuted fractures which can occur as well. Usually it's direct blow, as I told you, or it could be a high energy trauma which may result in a comminuted fracture of the mid shaft of the humerus. In elderly, this may be due to the transverse fracture, may be due to the there may be a pathological lesion over there in a form of they may be associated with the metastasis to secondary, some kind of a carcinoma, or there could be associated with multiple myeloma, in which there may be this kind of fracture results in a pathological fractures of the humerus shaft. Now coming to the clinical features. Clinical features include arm is really painful, it is bruised and swollen, and the patient complains that mostly it's in the middle part of the arm. Test for the radial nerve function is important because the radial nerve is actually going through the humeral groove transversely through the mid shaft of the humerus, and once usually in a comminuted fracture or in case of a high energy trauma, there may be associated with a radial nerve injury. Assessing extension at a metacarpophalangeal joint is important. Why? Because sometimes the posterior atrocious nerve may be resulting in this injury. There will be no extension of the metacarpophalangeal joint. Patient may be able to slightly extend the wrist joint due to other nerves being intact. Now, active extension of the wrist can mislead, so we have to see whether if there is a radial nerve injury, there will be loss of extension of the metacarpophalangeal joint, which is most pathognomic of a high radial nerve injury. Site of the fracture, its line and displacement is actually seen on the x-rays. Sometimes there may be associated soft tissue injury as well. If you see this is the long head of the bicep which is coming in from the rotator interval. As it comes down, if there is proximal humerus fracture, maybe getting stuck up involved in this, or if there's a spiral fracture, long spiral fracture involving the shaft, this head may be getting stuck in there as well. And this actually is a problem when we are doing the close reduction, because the tendon gets in between this. Usually this results in muscle contraction when reducing the fracture. Therefore, sometimes the close reduction becomes a problem, or it becomes difficult, and we may have to resort for the open reduction and fixation of the fracture. Now coming to the non-operative treatment, most commonly and mostly the shaft of humerus usually is treated non-operatively. Why? Because it's a fast healing bone and it gradually heals quickly. Arm is usually in form of an external cast in form of is called as slab is given, or coaptation splint is given, or we can give fracture humerus brace as well. Hanging cast is usually applied if it's a long spiral which is involving the middle junction of the middle third and distal third, but if the mid shaft, coaptation splint is most than enough. Functional polypropylene brace, which can, once this coaptation splint is kept for 2 to 4 weeks, after 4 weeks we can give fracture humerus brace or functional polypropylene brace, which can be easily managed because elbow and shoulder gets free and patient can move his or her elbow and shoulder joint easily. Wrist and finger exercises are commenced straight away, because if this initially in the coaptation splints, the elbow and the shoulder is actually immobilized. Therefore, the wrist extension and flexion and finger movements are started straight away. Once we convert into a functional humerus brace, then elbow and shoulder become free, and we can ask the patient to start active motion of the elbow as well as the shoulder joint. and pendulum exercises of the shoulder are started, then shifted to active shoulder and elbow exercises, and eventually strengthening exercises as the fracture heals. Now, operative treatment is only when either it's not meeting the criteria, there is a lot of anterior posterior angulation or mediolateral angulation, or is this more than 3 centimeter of shortening in the proximal humerus shaft of the humerus fracture, then probably we have to go for operative fixation. Or it is associated with high energy trauma and there is a floating elbow. There is a fracture of the, for example, shaft of the humerus along with the radius ulna fracture. So there's a floating elbow kind of situation. In this kind of a polytrauma, you have to fix the radius ulna as well as the humerus as well. Usually, if it's an open fracture or segmental fracture, this is always be a segmental fracture is indicative of very high energy trauma along with the open fracture. Then probably we have to go for operative treatment of the shaft of the humerus fracture. Either there is a displaced intra-articular extension of the fragment, it's a pathological fracture. Pathological fracture must be fixed, whether even if it is undisplaced fracture. It's a floating elbow, as I told you. In case of high energy polytrauma, there may be associated with floating elbow. A radial nerve palsy after manipulation, if initially there was not, but once you have manipulated it, this means there's probably damage to the radial nerve during manipulation of closed reduction, then it must be openly reduced and radial nerve spared, and we have to go for fixation of the bone as well. Usually if the coaptation splint was applied and patient later on developed either non-union, and then probably we will have to go for open reduction and tunnel fixation along with bone grafting to treat that humerus non-union as well. And sometimes we have to fix the fracture. Why? Because this kind of coaptation splint would require a time period of at least 4 to 8 weeks by the time the fracture would completely heal, and the patient will require a lot of nursing care as well. Sometimes the patient may not be senile enough to do this kind of care of itself. Therefore, we may have to go for early fixation and early mobilization of the patient. But this is probably a relative indication, but absolute indication is actually neurovascular injury, open injury, are associated with if it's a polytrauma or a floating elbow. These are the absolute indication in which we have to go for surgery in case of the shaft of humerus fractures. Now coming to the operative treatment. Fixation can be achieved with the compression plate and screws. That is, we open and we can go posteriorly as well as laterally as well as anteriorly, but most commonly the posterior approach is used. We can go for dynamic compression plate and screw fixation. If the other option could be intramedullary devices such as interlocking nail or semi-flexible pins or nails can also be used as well. Usually the interlocking nail can be done anterograde, which means going from the shoulder towards the distal part of the humerus, or retrograde, that is coming from the elbow upward towards the shoulder. But usually the antegrade nails are preferred, and because they do not need to open the fracture site. All you need to make small incision of the shoulder joint and go through using the jigs, we can place an intramedullary nail via close techniques. Other options in case of it's an open fracture, segmental fracture associated with neurovascular injury, probably we have to go for external fixator temporarily. This is kind of a temporary measure. By the time we fix the bone, if it's supposed associated with the neurovascular injury and it's an open fracture, we can fix the bone temporarily, we can repair the artery, and once the wound heals and the bed gets prepared, we can go for a definitive internal fixation in form of plates or nail as well. Antegrade nailing, as I told you, if this is the fracture, this is an oblique fracture of the mid shaft of the humerus, we do not need to open the fracture site. If we are going for plating, we'll have to open the fracture site over this area. We can make a small incision over here and put the intermediary device, as you can see it appreciated over here as well. This is usually with the rigid interlocking nail is inserted through the rotator cuff, and we do not need to open the fracture site under the fluoroscopic control most of the time. And why it's a better option? Because first of all, it's an intermediary device, plus it requires minimum dissection, and plus you do not need to open the fracture site, where there will be hematoma, and hematoma will help in the healing of the fracture site. A nail can all distract the fracture at time as well if there is associated with shortening as well. Now coming to the operative treatment. Operative could be antegrade nailing or retrograde nailing. Retrograde nailing, if this is the fracture, we have to go for antegrade nailing. Why? Because retrograde nailing would probably be problematic. But if the same fracture is associated with floating elbow, that is the one fracture present over here and another present radius ulnar bottom line as well, then probably retrograde nailing would be good, because all we need to do is open one joint. We need to open the elbow for the radius ulna. We can put the nail retrogradely and we can fix the radius ulna through the elbow joint as well. Other option is actually external fixation, but usually reserved for high energy segmental fractures associated with neurovascular injuries and open fractures mainly. Now we are fixing we are going for fixation of the shaft of the humerus fracture. Definitely every surgery has its complications. And what would be the complications of fracture shaft of humerus? Early would include vascular injury, nerve injury. Late would include delayed union, a malunion, or even the joint stiffness. This, if we have put an interlocking nail from the antegrade nail, this may eventually result in shoulder pain or shoulder stiffness as well. Special cases, in case of the children, we have to see is the fracture of the humerus are uncommon. But if they are present, we have to be tactful for the examination of other injuries. Usually they're associated with the thoracic as well as the clavicle injuries as well. So they can be easily managed by applying a coaptation sling or applying a cuff and a collar. Usually the cuff and collar bandage can be kept for 3 to 4 weeks. And unless there is more than gross shortening or more than 3 centimeter shortening, there is a gross angulation in form of anterior-posterior plane or mediolateral plane, most of the fractures can be easily managed in cuff and collar. If it's an older children, we can go for short plaster called as coaptation splint, which can be later converted to fractured humerus brace as well. In this section, we have briefly gone through the indications for surgery, especially in the case of mid-shaft humerus fractures. Whether adults and the children, most of these fractures are managed conservatively in form of coaptation splint, which can be later converted to fractured humerus brace. And initially, at the time of coaptation splint, we can start with the finger and flexion wrist exercises. Once the fractured humerus brace is given, then the patient can actively start exercises with the elbow and the shoulder as well. But if it's an open fracture, if it's a polytrauma, it's a floating elbow or associated with neurovascular injury, then we may have to operate these patients. Operative options could be simply dynamic compression plates in form of with screws as well, or it could be intermediate devices such as either intermediary nails or retrograde intermediary nails. But if it's an open fracture associated with neurovascular injuries, the temporary method is to go for external fixation till the wound bed is prepared, and we can go for definitive internal fixation in form of plates or nails as well. Thank you very much. Keep watching sqadia.com.